Today we discuss the acute bronchiolitis. The causative organism represented the microbiology. The acute bronchiolitis caused by many different microorganisms, but the most common one is respiratory syncytial virus that represented the most common, about 50%. Other viruses like parainfluenza, influenza, rhinovirus, coronavirus, human buccavirus, and human metapneumovirus. Also, the acute bronchiolitis occasionally associated with Mycoplasma pneumoniae infection. The risk factors of severity of acute bronchiolitis, like the prematurity, low birth weight, the age less than 6 to 12 weeks, chronic pulmonary disease, hemodynamically significant cardiac disease, immune deficiency, neurological disease, and anatomical defect of the airway. The bronchioles represent the small airways in the lung. The itis, it means inflammation. So the bronchiolitis, it means acute viral respiratory illness due to inflammation in the bronchioles. The most common is respiratory syncytial virus, affecting small age group of the children. So when the virus attacking the upper airway, the virus still in the nasopharynx and then pass to the main target organ, the cell lining the bronchioles. So the respiratory syncytial virus, when arrive to these cells, the changes occur, destruct the septa between the cells and form a group of cells named syncytium. So the name of the virus, respiratory syncytial virus. The respiratory syncytial virus is a pneumoviridae virus. Is the virus pass from the sneezing and coughs and traveling about 2 meters to landing on to other person. So the respiratory syncytial virus may be staying in the nasopharynx until taking the time until to pass through trachea and arrive to the bronchioles to affect the bronchioles, the lining cells of the bronchioles. You know, this is the multiplication of the virus inside the respiratory epithelial cells, and now you notice the disappearance of the septa between the cells, and these cells lining the bronchioles is columnar ciliated epithelium. You notice the no cilia that help to remove every debris of the cell or thick mucus. These destructed cells, you know, these destructed cells and appearance of the new vascularization, this is the red line from blue. This is leading to the depressed cells or dead cells, thick mucus secreted by the goblet cells that replace the destructed columnar ciliated epithelium, producing thick mucus. So collection of thick mucus and debris and submucosal edema lead to narrowing of the already narrow airway, the bronchioles diameter more or less 2 millimeters in diameter. Now this is the bluish color, this thick mucus, and from downward this is submucosal edema and narrowing This is more explained at the previous one. The end result of collection of thick mucus, depress, and submucosal edema lead to obstruction in the already small airways of the bronchioles. If the obstruction is partial obstruction, the air pass inside the alveoli for gas exchange, and the limited time for expiration, not all the inspiratory air can pass during expiration, but the remaining part of the air inside the alveoli lead to hyperinflation. Like the figure below, lead to hyperinflation of the alveoli. But if the collection of the thick mucus, depress, and submucosal edema lead to complete obstruction of these bronchioles, lead to absorption of the air inside the alveoli and form absorption form gaps. This is clear. This in a slideshow. This is as previous. Remember, the virus is the most common causes, and the most common one is respiratory syncytial viruses. The symptom when the virus remaining in the upper airway lead to the fever, cough, sore throat, and when the virus progressing downward to the bronchioles lead to the fever continue, difficulty breathing, and wheezy chest. Affection of the bronchioles and the respiratory function, the functional part of the respiratory system. This is the respiratory acinae, lead to hypoxemia. This slide shows the respiratory syncytial virus affecting 80% below 1 year and 100% near to the 2 years of age. The conducting bronchioles terminating by subdivision, this is the terminal bronchioles. The terminal bronchioles ending by the smallest airway to be opening in the function unit in the alveoli, this is respiratory bronchioles. Collection of the alveoli, yes, this form the alveolar sac, and this is the upper part conducting bronchioles, and this part representing respiratory bronchioles. So the upper part conducting zone and the lower part representing respiratory zone. This diagram showing when partial obstruction occur, not all the air passed during inspiration can take time for expiration, so more and more air trapping inside alveoli. This leads to hyperinflation. The hyperinflation, yes, hyperinflation may be pushing in the blood vessel nearing to the alveoli, affecting the passage of the blood. This is named perfusion. Yes, this is clear. Affection of the passage of the airway. So the perfusion, more and more affection of the perfusion. So impairing the gas exchange. How to diagnose the acute bronchiolitis? Diagnosis of acute bronchiolitis clinical. This depends on history from the mother. This is upper respiratory symptom in the form of fever, running nose, and cough. Then wheezy chest, followed by difficult breathing. So from the history, this is very important. The vital measures in the form of temperature, the heart rate, and lastly on physical examination. Physical examination in the form of inspection to the shape of the chest. This is acute illness, so no change in the shape of the chest, normal shape of the chest. Also during inspection we comment on the trachea normal in position, and the chest movement. This is affection of the movement, diffuse affection of the chest movement. Then after inspection, this is palpation to confirm the already observed during inspection. Then percussion. The percussion differ from area to area. If the area, lastly explained, if the area underlying percussion occurring complete obstruction lead to the relaxation form of collapse, so there is impaired note. But if percussion over the area occurring hyperinflation lead to hyperresonance. And the auscultatory finding including the vesicular breathing associated with prolonged expiration, also sibilant rhonchi scattered all over the chest, front and back on post lung fields. So the diagnosis depends on clinical in the form of history and clinical finding in the form inspection, palpation, percussion, and auscultation. Also laboratory investigation, chest X-ray to exclude other abnormalities if hemodynamic cardiac lesion or pulmonary lesion, or a complication of the disease like pneumonia and bronchopneumonia that's occur. Also the diagnosis depend on the lab in the form of nasal swab for viral detection. So the X-ray, the nasal swab, CPC to detect total and differential leukocytic counts. Viral identification by different methods, complement fixation and PCR for the virus. This diagnosis and on clinical diagnosis supported by X-ray form hyperinflation, flattened diaphragm, air bronchogram, peribronchial coughing, patchy infiltration, and atelectasis. Also the diagnosis on the viral identification. Nasal wash or nasal aspirate, rapid antigen detection, direct and indirect immune fluorescence culture, and PCR. The differential diagnosis, any differential diagnosis including the causing of wheezy chest. The most important, this is first attack of wheezing chest or history of recurrence. First attack, this is including first attack of bronchiolitis, foreign body aspiration, and the recurrence of wheezy chest. The top of this issue is bronchial asthma. But other viruses may be causing bronchiolitis, different viruses. This is bronchitis, pneumonia, including in the differential diagnosis, gastroesophageal reflux, congenital heart disease and heart failure, vascular ring, bronchomalacia, anatomical abnormalities. What is about the treatment of the patient? This is very important to detect the severity of the condition. This is depend on pulse oximeter to measure the oxygen saturation in room temperature, and you detect from the start the risk factor. If high risk factor and the oxygen saturation in the room temperature 92%, this is hospital admission. This is high risk factor, but the oxygen saturation more than 92%, this also hospital admission. If low risk factor but the oxygen saturation in the room temperature less than 92%, also hospital admission. The only one for home medicine and discharge and instruction to the patient if this is low risk factor associated with oxygen saturation and room temperature more than 22%. All the medication directed to improve the oxygenation of the patient. This is maybe direct by giving oxygen or indirect by the medication in the form beta-2 agonist, hypertonic saline, corticosteroid, and epinephrine. All these intending to increase oxygenation. So the treatment can be titling by supportive care, pharmacological therapy, ancillary, evaluation. Supportive care in the form of adequate fluid intake, saline nasal drops with nasal pulp suction, routine, deep suction not recommended, antipyretics, and this associated is monitoring the oxygen saturation, the heart rate, respiratory rate, and APG to detect the case still in the ward or needing for a referral for ICU. Respiratory support in the form of oxygen to maintain saturation above 92%, but keep the saturation higher in the presence of acidosis, hemoglobinopathies. Special care in the children, acute bronchiolitis associated with heart disease, chronic lung disease, and prematurity. Mechanical ventilation depending on the results of APG if the CO2 more than 55 or the condition associated with apnea. Fluid administration depend on if the presence of dehydration coming from fever, tachypnea, secondary gastroenteritis associated with vomiting or diarrhea. The bronchodilator generally not recommended or helpful, but it is very important. Trial with albuterol or epinephrine may be appropriate. This is depend on the risk factor. This is depend on the severity of the condition, positive family history, atopic parents, or one of the parents. Corticosteroids also is beneficial as the same factors like the bronchodilator, if history of atopy to the baby or history of atopy one or both of the parents. Ribavirin not routinely recommended for all patients, but this is in selected patients, especially on the mechanical ventilation. Antibiotics, this is depend on the CBC if the total leukocytic count is the total leukocytic count is very high and shift to the left. And the X-ray if the X-ray indicating pneumonia or bronchopneumonia underlying the title of consolidation or associated with complication like otitis media. Complication is apnea, respiratory failure, secondary bacterial infection in the form of pneumonia and bronchopneumonia, also gastroenteritis in the form of diarrhea and vomiting leading to dehydration. Discharge criteria: improvement of the respiratory rate, improvement of the oxygen saturation in the room temperature, and the child can freely taking food. Association with asthma, this is depend on the frequency of the wheezing, the severity of the presentation, and duration of illness. Also, the history of atopy or atopic lesion in the child, or atopic lesion in one or both parents of the family. Prevention: good hand washing, avoidance of exposure to smoking, avoidance contact with individual with viral illness, influenza vaccine for children more than 6 months of age. PALIVIZUMAB, this is humanized monoclonal antibody against respiratory syncytial virus, is indicated in the prematurity associated chronic lung disease, congenital heart disease, given monthly through the season of respiratory syncytial virus.